In today's video, we are going to solve few of the multiple choice questions related to neonatal jaundice. Which of the following is the most important cause of jaundice presenting in the first 24 hours of life to exclude? Options are hemolysis, breastfeeding, physiological jaundice, and prematurity. Hemolytic jaundice is the most important cause of the jaundice presenting on the first day of life and needs to be excluded. Breastfeeding jaundice does not cause jaundice during this period. Physiological jaundice normally presents after 24 hours of the life, so that is not an option. And jaundice of prematurity normally presents after 24 hours of life. So, correct answer to this question is option A, hemolysis. Next question is, jaundice is the most likely to be physiological in a term infants in which of the following situations? Jaundice presenting at 12th hour of life, serum bilirubin increasing less than 5 mg per deciliter per day in the first 2 to 4 days, direct serum bilirubin more than 2 mg per deciliter, or jaundice at 15th day of life. To know the answer, we should know the difference between physiological and pathological jaundice. So this is the difference between a physiological and pathological jaundice. Physiological jaundice appears after 24 hours and it persists till 2 weeks of life, while pathological jaundice appears before 24 hours and it lasts longer than 2 weeks. Physiological jaundice serum bilirubin level is less than 15 mg per deciliter. In pathological jaundice, this level could be more than 15 mg per deciliter. In physiological jaundice, rise of bilirubin is less than 5 mg per deciliter per day, whereas here in pathological jaundice, rise of bilirubin is more than 5 mg per deciliter per day. Physiological jaundice, direct bilirubin is always less than 2 mg per deciliter, while in pathological jaundice, direct bilirubin is more than 2 mg per deciliter. So, jaundice at 12 hours of life is not physiological. Serum bili increasing less than 5 mg deciliter per day is physiological. Direct serum bili more than 2 mg is pathological jaundice, and jaundice which persists beyond 2 weeks of life is also pathological jaundice. So correct answer to this question is option B. All are the causes of unconjugated hyperbilirubinemia except hypothyroidism, G6PD deficiency, breast milk jaundice, or galactosemia. Quick revision of causes of unconjugated hyperbilirubinemia. Based on the mechanism of bilirubin elevation, the etiology of unconjugated hyperbilirubinemia can be divided into the following categories. Either it is increased bilirubin production, increased hemolysis, or reduced clearance, non-hemolytic. The first mechanism to consider is increased hemolysis of red blood cell, which leads to increased production of unconjugated bilirubin. Etiologies of increased hemolysis in a newborn include isoimmune mediated hemolysis, which is to say ABO or RH incompatibility, kiphelhematoma, polycythemia, membrane defects such as spherocytosis, and enzymes deficiency in like G6PD deficiency. In reduced clearance, apart from syndromes, hypothyroidism is one of the important causes to be remembered. And reduced clearance could be because of increased enterohepatic circulation, that includes breastfeeding jaundice, breast milk jaundice, and other causes like ileus and intestinal obstruction. Now back to our question. In hypothyroidism, there is no thyroxine, which will lead to reduced activity of UDP enzymes, which lead unconjugated hyperbilirubinemia. Because of G6PD can lead to hemolysis and unconjugated hyperbilirubinemia. Similarly, breast milk jaundice is because of increased enterohepatic circulation and reduced clearance. So here these three, A, B and C, are the causes of unconjugated hyperbilirubinemia, while galactosemia is not a cause of unconjugated hyperbilirubinemia. Next question is, phototherapy reduces unconjugated bilirubin level by which one of the following mechanisms? A, isomerization of bilirubin molecule to lumirubin, which is water soluble and can be excreted by the kidney. B, direct conjugation of the bilirubin molecule, which allows it to be excreted by liver, induction of liver enzyme. Or D, isomerization of bilirubin molecule causing it to be sequestered in the skin and then be destroyed by macrophages. So phototherapy works by two mechanisms, photooxidation and photoisomerization. In photoisomerization, molecule is broken down to lumirubin, which is water soluble and then excreted by the kidney. So correct answer to this question is option A. Next question is, 4 weeks old infant has been referred to you because of jaundice. She was born by vaginal delivery with the birth weight of 3.3 kg with no perinatal complications. She has been given discharge on third day of life, and on investigation today, her direct bilirubin is 10 mg per deciliter with indirect fraction of 2 mg per deciliter. Mother reports that she has always breastfed, but that the baby has struggled to gain weight. Her current weight is 0.5 kg. She is passing 6 to 8 times dark urine and 3 to 4 times pale stool per day, and on examination she is jaundiced with bronze tinge to skin. Her neonatal screening is normal. Which one of the following is the most appropriate management? Stop breastfeeding, start phototherapy, reassure the mother, perform thyroid function test, or arrange urgent abdominal ultrasound and liver function test. This is the case of failure to thrive with direct hyperbilirubinemia, pale stool, dark urine, as well as the report of direct bilirubin suggest it is conjugated hyperbilirubinemia. It is not a breast milk jaundice, so option A is not going to help. And stopping breastfeeding in case of breast milk jaundice is not an option. Start phototherapy. This is conjugated hyperbilirubinemia and it requires urgent investigation. Phototherapy will not reduce the level of jaundice. This baby doesn't have breast milk jaundice and requires immediate investigation, so reassuring the mother is also not an option. Hypothyroidism can cause unconjugated jaundice. This baby has direct hyperbilirubinemia, and to rule out biliary atresia and hepatitis and the other causes, full set of investigation has to be done. So option E is the correct answer. Yeah. The next question is, a 3-week-old newborn presents to the hospital with jaundice. Her blood report shows total bilirubin of 12 mg per deciliter with direct portion of 4.5 mg per deciliter. Which of the following disorder is most likely to be responsible? The first option, ABO incompatibility, will give rise to unconjugated hyperbilirubin. Could be biliary atresia. Let's see the other two options. Hypothyroidism will also give rise to unconjugated hyperbilirubinemia, as well as the Crigler-Najjar syndrome will also cause unconjugated hyperbilirubinemia. So correct answer to this question is option B, biliary atresia. Thank you for watching this video on neonatal jaundice. Hit the like button, share and subscribe to the channel.